Okay, so welcome back, everyone, and thank you for being here. We are now in the fall semester of 2023, and the course we're covering the semester is the healthcare bioethics in healthcare provision within the Masters of Bioethics at St. Thomas University. So we have 8 modules for this course, all right? And this course is actually team taught. I'm recording this also so Kenny can catch up on everything. And so there'll be 8 modules, and it's team taught, meaning that I teach 2 of the modules. I teach a module today on transplantation bioethics, and then I also teach a module on the bioethics of pandemics and vaccine development. And that one was introduced, of course, since COVID. We'll look at that one later on. Usually it's the last one, but we can adjust the schedule also. The other 6 modules are on videos, and they're taught by medical doctors in different fields of profession. Okay? And these medical doctors they're all friends of mine from here, from Miami. They're members of the Catholic Medical Association, and they taught originally in the first cohort that we had 7 years ago. They taught live, and we recorded that teaching, that lecture. And so those are the modules that you'll be seeing in this course. All right. So to say that 2 will be live like this in person, and the other 6 will be virtual, and I'll send you the links to each with the topic, the title of each one of those. All right, again, if there are any questions or comments about anything, just stop me along the way. Otherwise, we'll go forward with this one. This one of the bioethical issues in healthcare today is the whole issue of transplantation. And this is a field that has grown tremendously since like the middle of last century. You may recall Dr. Bernard, who was the first one who did a heart transplant in South Africa way back, I think it was in the 50s or something like that. It was certainly an experimental procedure, and he was successful for a little while, but the patient did die relatively soon after the transplant. But that was pioneer work, and it was basically what we call proof of principle that vital organs can be transplanted in humans. Of course, after much research that had been done in animal models, right, that were progressively successful. And the big thing of what made that clinically possible was also advancement in the whole immune system, studies in the immune system of human, and what is known as immunosuppression. Because the key issue with transplantation is that the organ or tissue, it can be tissue also, that is transplanted into the recipient, that all is detected by the body of the recipient as foreign, right? So the immune system mounts a reaction, an immune reaction, to attack and kill that foreign object, which is either a vital organ or tissue that is actually trying to save the health or the life of the patient. And therefore, the typical thing that has to be done is immunosuppression, which is to tone down the immune system of the patient, but not shut it down altogether, because then that exposes the patient to all kinds of infection. we have to realize that anything that we eat is not sterilized, right? And even the air that we breathe is full of bacteria and viruses and spores from fungi and so forth. So we need an active immune system to keep us alive on a daily basis. So these transplants are detected by the patient's body as foreign body, and therefore they're attacked by the immune system, and therefore that immune system has to be toned down. It's called immunosuppression. And it's tweaked almost, it's getting better and better and better toward what we call personalized medicine, because the immune system is very personal. It's like the fingerprint of our bodies, right, internally. And it is very, very personalized. So to find the match is a big thing, to find the match, all right? We'll get into that a little bit. But before we do that, I just want to get into some terminology. So transplantations can be done either cadaveric or living. Cadaveric meaning that the organ or tissue is coming from a dead person, from a cadaver, all right? Whereas living is that the donor is still alive. Of course, the donor has to be in good health to donate, because they're not going to risk the life or the health of the donor to try to save the life or the health of the patient. So you can see that the issue has many layers of complexity, and we have to really peel those layers through to find that there will be ethical issues at each layer that we encounter, all right? Of course, if it's living, there has to be consent also, even for cadaveric. The next of kin typically has to consent for the donation. And the patient, of course, also has to consent to receive the organ or the tissue. That's standard procedure nowadays. All right, so going forward then, some further terminology. It depends where the transplant is coming from, all right? It could be autologous or an autograft. An autograft is from the same patient, from one part of the patient to one, say, tissue from the leg to a burn on the arm of the same patient, all right? And that's called autologous or autograft. And of course, the big advantage of this one is that it bypasses the immune rejection because it's the same patient.
So right? Like someone who's gotten burned.
Yes, that's a very typical thing. Another one is sometimes they extract bone marrow before a cancer treatment, right, for leukemia or something like that. And that bone marrow contains stem cells of the patient. After the treatment, they re-inject the patient with the stem cells collected from his or her own bone marrow, because the chemotherapy is going to essentially shut down their immune system. And so they are repopulated with their own stem cells.
Is it like the same thing, like, you know, how with ACL surgery, how they take from the hamstring?
Yes, that's another one. From one part of the body, they can take ligaments, tendons, right, from one part of the body to another one. Bone graft, for example, to reconstruct the jaw from other parts.
Reconstruction for cancer too, I mean.
Which one? Breast reconstruction, yes, typically.
Lots in the back.
I have a friend who just went through a double mastectomy, and they take fat. So if there's any silver lining about that, is that they can become a little slimmer other parts of the body because they use fat for the reconstruction procedure.
And then they grab the muscles back here too, on the back.
Oh, really? They do?
Like, they're called flaps or something.
The
like
flaps,
that.
yes.
Yeah.
Oh, okay. Really? Okay, I didn't know that. All right. But yeah, they're getting very, very creative with the patient's own body, right? And that's a good thing, again, because of this bypassing the immune rejection. The other type, of course, is allograft, and the allograft is from a donor who is not the patient. And again, the two options there are that the donor is either living or cadaveric, but then we have to deal with immune rejection. The third option is actually between from a donor who is not a human being, okay, from an animal. And this one is called xenotransplantation, when it's between different species. And the classical for that is the pig valves of the heart valves, because it turns out that the anatomically and physiologically, the pig heart is very similar to the human heart. And so the heart valves from pig can be used in human. This has been used for many years now. And of course, what they do beforehand is they strip those valves with just about everything that they can take off possibly, and still maintaining the integrity of the heart, of the valves for the transplant. And also they're sterilized and all that, so that there's no infection, right, coming from the pig. But xenotransplantation is between different species. In this case, the pig and the human. All right, going forward, the organs that we're talking about, they're the heart, the kidney, the liver, the lungs, pancreas, intestines, thymus gland. The most common are kidney, liver, and heart in that order. And those can either be living or cadaveric. And for living transplants, so that the donor is still alive, in other words, the donor donates and keeps on living, the kidney, the liver, and the lungs. We'll look at some cases of that briefly. All right, then tissue can also be transplanted. I mentioned that earlier. Bone marrow, tendons, cornea, skin, heart valves, nerves, veins, stem cells. And the advantage of tissue transplantation is that many of these tissues can actually be frozen and therefore banked and also shipped nationwide and so forth in these conditions, all right? Whereas cadaveric organs need to be fresh, and the typical window is 24 hours after removal, and then connected to the patient, to the recipient, right? So that's the general window there, is up to 24 hours. And this also includes everything from the moment the person dies, the donor dies. And the typical donor, so who is a typical donor? The typical donor is a motorcycle rider who gets into the crash, flies through the air, lands, and breaks his neck or her neck. And if they don't become paraplegic, they die from a traumatic head injury that leaves the body fairly intact from the neck down, the internal organs, especially the core, right, the trunk area. And this delves into, when we talked about the declaration of death, this would be the neurological criterion for declaration of death. And remember, it has to be total brain death, including the brain stem, right? Again, you can imagine the complexity of the scenario of the transplant team approaching the next of kin, whoever that is, could be a spouse, could be parents, could be children. At that moment of great grief, if they want to have their deceased loved one donate a vital organ or more, okay? And because of that, and so that there's no even perception of conflict of interest, the transplant team, the clinical transplant team, including the doctors, nurses, anesthesiologists, and all that, is a totally separate team from the healthcare team that receives this patient through ambulance or through helicopter in the trauma center of the hospital. All right, you know more details about that than I do, being an MT working with rescue teams. But those two teams, so the emergency room team, for example, that receives those clinicians who receive that patient, right, who could be living or dead or just on their last breath, is totally separate from the transplant team. But both teams are alerted simultaneously, just in case that the patient does die and some organs are rescuable, right? And the next of kin do agree to make that donation. And then once they get the go-ahead, the transplant team goes into high gear to try to save as many organs as possible from the cadaver. And I can also tell you that the cadaver will be immediately hooked up to life support system, not to save the cadaver's life, right? Because there has been a declaration of death also. A clinical declaration of death, right, has to be in place, which has legal implications. And then they'll do things like they'll heparinize the blood, for example, so it doesn't coagulate. Right. Then they'll put them on a vent, and you see this cadaver breathing. And heart maybe beating, okay? But it's all artificial. The person has been declared dead officially, legally, clinically, and all that. And then the transplant team comes in, they harvest whatever they can, and right away that's transported within 24 hours to the recipient, who could be on a bed next door or across nation on another state. And so flights are organized and all that. And this begs the question of a matching agency that is monitoring the match in the background, which can all be done by computer, but the match has to be made, all right? Because again, the match could be a heart patient at the room next door in the hospital, or could be a liver patient in Washington State, in Seattle. And how to do the match. There are actually two agencies that are national agencies that run those registries. And they run 24/7 to find a match.
Is that like UNOS?
UNOS is one, and the other one is there's one for the patient and one for the recipient. We'll get to them. All right, let's go forward a little bit more on the clinical side of things. I talked about the immune response of the transplant rejection for allografts. So there is a matching scale, and each organ or tissue has its own specific matching scale, right? To essentially determine the suppressant drugs that are going to be needed for the patient regarding the level of match. And it's not an all or none thing. The matching is not yes or no. There's actually a scale. The one I'm more familiar with is the kidney matching scale, which is like from 1 to 4. And anything from 2.5 up qualifies for donation, for a match, all right? And so a couple of things they do serotyping, which has to do with the surface, typically of bacteria or viruses and the immune system. So they test on that to determine specifics about the immune system of the patient. And then to try to custom tailor the immunosuppressants that the patient will need for that particular organ or tissue. And then they do what is known as a panel reactive antibody level. It's an assay that is done. It's a biochemical assay that is done on the donor and recipient to see what is the level of match. And so it's called the PRA score, PIA for panel reactive antibody, right? And that score is the one that's used to find the match, and that's what's put into the registry to see where is a potential recipient for these organs or tissues that are available. Now, some PRA scores get sensitized, which is when a patient has had a previous transplant, for example. All right, that patient's already sensitized.
A previous one, sorry?
A previous transplant,
Oh, okay.
right? I'll give you a case where the kidney patient had received already 2 cadaveric kidneys. Right, so she really didn't qualify for a third one because, you know, there are other people who are there are 100,000 people on the waiting list for a kidney right now in the United States alone, and about 15 are dying every day.
But when you have someone who's already been through, let's just say 1 transplant, and I think the average lifespan is like 5 years for a kidney, although they're going longer now.
It depends, yeah, it depends if it's living or cadaveric. Living is about 7 years. I'm sorry, cadaveric is about 7 years, and living is about twice as much, about
Okay.
15 years.
So they don't go in, once that kidney that's been transplanted has had it gets out.
Yeah, yeah.
They don't take that out.
They don't take
It
out,
stays in, they'll put in a
stays.
new one. But
Yes.
now we're dealing with that person's body having their own DNA,
yes,
the existing kidney that was transplanted, that DNA stays there, even if that kidney's not.
correct,
working.
correct. That kidney is on kidney failure, and they don't excise it. They leave it there,
Okay,
and they leave the 2 original kidneys also. They don't
okay.
take those out because it's different location. When we get to the kidney example, I have more details, and you'll see. But they put the kidneys, the transplanted kidneys go much closer to the bladder, not up, because our kidneys are way up here
Right.
on our back, kind of at the end of the ribs. All right, because the ureters are shorter and so forth. So, but you'll see how it works. It's quite fascinating.
So in finding a match for a second kidney,
Yeah,
for a second transplant,
right.
is what causes the difficulty, the fact that you have 2 different DNAs already floating in there, or what's causing?
Not necessarily, because that second kidney is nephrotic, it's dying or dead. So if the immune system wants to go after that kidney, so be it, you know.
Okay,
They're
but-
focusing on the new
I'm
kidney
talking about
that's
the-
gonna be
like, what
transplanted,
makes it
yeah,
harder? If I've already had 1 kidney transplant and that
Right.
kidney's already gone into failure.
right.
What makes it harder for me to get the second one? What is my body? doing?
Because your immune system has already been sensitized, and you're on immunosuppressors anyway,
Right,
okay?
I see.
So it's a more complicated, remember, the immune system is really, look at it a little bit like allergies. You know how allergies, some people are born or have allergies as young and then they disappear
Right.
older, or vice versa. Some people become sensitized
Right.
older with pollen and stuff. That's all immune system.
Right.
It's a very complicated scenario, the immune system.
So it's more like
Okay.
you're gonna reject because you're already on these.
Yes, it's hyper. One time when I was doing my research at Purdue, in the lab, accidentally, I must have touched something that was toxic and irritated me. And so my immune system went into high alert. And to the point that almost anything I touched for a whole week would make me an immune reaction. And I was breaking out, flaring out all over the place. And so I went to a dermatologist to get a test to see what was causing this allergic reaction in the lab where I was working. And he was going to do that skin test on the back. He says, "No, Father, we have to wait at least another week or 2 because," he says, "your back is very angry," he said. He just touched it and it flared, you know, it became
Wow.
reddish.
So anything to the touch. is a
Yes,
problem.
yes, even putting on clothing was painful and stuff. It was something that I must have touched in the lab accident. It was super toxic, and it just sent the immune system way
Wow.
through my whole systemic, through my whole body. So a little bit, that was the overreaction. That was the overwhelming reaction of the mRNA vaccine for some people of the COVID, right?
Yeah,
It was
I
an
got-
overwhelming reaction, and so that the immune system was starting to kill itself, start to attack the patient's own lungs. And that's how we lost some patients because of that. There's a word for that, but it's an overreaction of the immune system, overwhelming, and it starts attacking its own organs. Okay, so there's a sensitization there. Another one, of course, is with pregnancy, right? Because keep in mind that the baby is half friend and half foe because of the father's DNA. So that already has sensitized the mother's immune system to a foreign or a half foreign object within her. Transfusions can also do it because necessarily the transfusion, well, there are autologous transfusions that are done now. They're getting really creative also because the blood banks are having a very hard time getting blood nowadays. So the new creative thing is that they take out blood. If the patient is going for some kind of surgery, they take out the patient's own blood first and bank that. And then after the surgery, they may or may not put it back, depending if the patient needs it or not, depending on how much blood the patient lost in the operation, in the surgery. Okay, so all these things can sensitize the patient, and therefore the PRA score may require a higher standard. All right, moving forward, the transplant area has gotten very creative also in what they call domino transplants. That involves more than 2 patients. The simplest case is paired donations.
What donations?
Paired donations. I think I have a slide on it, but it's further down. No. So pair donation here is this. Let's say you have, I used to have a diagram on it. Pair donation is, let's say you have 2 pairs of donors and recipients, okay? So let's call them A, B, C, D. And A and B, so A is the donor, B is the recipient. That's one pair. And then there's C and D. C is the donor for D, and D is the recipient for C, all right? However, it turns out that A and B are not a good match, and C and D are not a good match. But A and D are a good match, and C and B are a good match. So A and C are the 2 donors, right? So A and D are a good match, and C and B are a good match. And so they flip, you know, and they do the 4 operations, the 4 surgeries simultaneously so that nobody backs up or backs out, not back up, backs out. They do the 4 operations in 4 surgery theaters simultaneously so that nobody backs out, because, you know, if let's say that A donates to D, well, D now has the new transplant, so D walks away, leaving B without C's donation, because now C's friend got the donation already, and vice versa. Okay, so that's called pair donation. Is the simplest case, and this particular with kidneys, which happens to be the thing. I'm going to highlight kidney because several factors. Number one, there's the highest demand on the transplant list by far. Kidneys is about 100,000 that are on the kidney list right now. All right, and waiting for a transplant only in the United States. And like I mentioned earlier, about 15 to 17 are dying every day for lack of transplant. Okay, so that's one. They're on dialysis. The other one is, it's actually the easiest organ to donate living, because we have 2. And a person can live with 1 as long as they have good health, no problem, because they're not going to risk the life or the health of the donor, you know, to try to save a patient. So that's the other thing. And even the recovery for the donor is usually within a week. It's a recovery. All right, so it's fairly, it can be done laparoscopically also with the Da Vinci robot. Okay, so that has other advantages, it's minimally invasive and so forth. So a number of advantages for kidney, and that's why I'm highlighting.
So it only takes the donor a week for his body to adjust to filtering through one kidney.
Yeah.
versus-
Yeah, and the one kidney,
I thought it was tougher for them.
yeah, no, as long as they're in good health, okay. The solitary kidney, it's called solitary kidney, actually grows a little bit also to compensate for the increase in flow, all right? But yeah, it's just amazing, but it can be done. Okay, before we go into this domino kidney, I want to show you another example. I'm looking at this presentation is missing some slides that I had with diagrams, and I'm wondering why that is. Give me a minute, I'm gonna go into my data bank because I may not have pulled out the latest PowerPoint. I can do that by going to, well, I have my laptop actually. It'd be easier for me to navigate. Because I have some diagrams that shows this more graphically, and it's visually easier to follow. But I'm thinking that I used an older version of the PowerPoint courses. Oh, give me a couple of minutes here. Yeah, sure. Oh, yes, yeah, here it is. Yeah. Well, we can do this. It's 10:30, so if you all want to take a break for a few minutes while I transfer this from my laptop into the projector. All right. So take a few minutes break. I'm gonna pause the recording while I do all this manipulation. Here we go. So to reiterate, these are some numbers in the US of patients waiting for various vital organs. And as you can see, for kidney is by far the largest demand, over 100,000. Liver, 13,000. Heart, almost 4,000. Lungs, 1,000. And the pancreas, less than 1,000. Now, the agencies that are handling this, as was mentioned earlier, one is UNOS, the other one is the OPTN, right? Which stands for Organ Procurement Transplantation Network, otherwise known as OPTN. And UNOS, which is the United Network for Organ Sharing. Now, these two agencies are at the national level, they're national registries, and they are a consequence of an act of Congress called the National Organ Transplant Act, or NOTA is the acronym, in the 1980s, because before the 1980s, there was really no uniform system of transplantation for organs or tissues in the US. And that led itself to speculation about buying and selling of organs or organ trafficking, right? And so Congress decided to regulate this at the national level, and it generated a law, essentially an act of Congress, which was then ratified by the president at the time. And essentially it generates these two agencies, OPTN, which is the one that receives the organs. I put it in quotations, I'll explain that in a minute. And then the UNOS is the one that allocates the organs. So again, there are two agencies that are interdependent, right? But one receives the information about the organs or tissues that are available. So it's actually a computer registry of the match. In other words, it has the basic panel of the patient, aside from the data of the age, the sex of the donor, usually if there are pre-existing conditions or illnesses or treatments like chemotherapy and so forth, the donor no longer qualifies, okay? But the state of health, and then the PRA scores, all that is put into OPTN computer system, right? And that's the bank. And then UNOS has similar list, but of the patients, right? So we can say that OPTN receives data from the donor, whether living or cadaveric, and then UNOS is trying to find the match from the registry that they have of patients who are waiting, precisely all these folks here, okay? And that's how the matching is done. Once the matching is done, as you can see, these computers are running and talking to each other 24/7, right? Because accidents are happening all the time, and donors are coming forth all the time also throughout the whole US. And as soon as that match is made, then everything goes into place to get that organ or tissue to the patient. Now, one thing that is also important in the United States is what is known as a targeted donation. A targeted donation bypasses the waiting list. This is not true in other countries. For example, in Europe, they can have targeted donation from donor to recipient, but it doesn't bypass the waiting list because they have more socialized medicine. So their sense of justice is a little different. Ours is more kind of parallel to a market economy thing. There's a supply and a demand, but for theirs, because of socialized medicine, is more centralized. So let's say a kidney patient in Europe has a donor who may be a relative or a friend who is a good match, so they can donate to their loved one, but the loved one still has to go on the list. In other words, they have to, the donor actually has to donate to someone on the list that is a good match. And it does help their patient in that it puts the patient up further on the list, right? But they cannot bypass the waiting list. So it's a little more awkward in Europe. And these donors might end up donating sometimes to people who are not the loved ones. And it helps the patient in moving them up on the list, but it's not that significant. Here in the US, if let's say we're patients that need a kidney, a heart, whatever, well, a heart, there's only one case that I know of that can donate a living heart. We'll see how that happens. How do you donate a living heart? You'll see how. Anyway, if it's a target donation, it bypasses the waiting list and they just go for it. All right. And so these people, the waiting list, are constantly looking for donors, family or friends who may consider the case. So let me talk about the one case that I know of when one can actually donate a living heart and keep on living. Very strange, but you follow the science on it. All right. It's a case of a double transplant of heart and lung. All right. And this is with cystic fibrosis. CF, which is a debilitating illness of the lungs. What happens is that the lungs, or it's a genetic condition that is inheritable, and the lungs begin to fill with mucus, which then hardens and the lungs become fibrous, and they start running out of space for breathing. And so they kind of asphyxiate to death eventually. You know, they have to be on a oxygen machine and so forth to assist them to enrich their breathing. So basically what a cystic fibrosis patient needs is what kind of an organ?
Lungs.
New lungs, because only the lungs, important, only the lungs are dying or are ill in a CF patient, all right? So they need lungs. It turns out that for anatomical reasons, it's actually easier to transplant the heart and the lungs together from the cadaver into the CF patient. So the CF patient gets new lungs and new heart because that whole trunk is transplanted directly together. They have to do less cut and less anastomosis. Anastomosis is the sewing back. That's what takes the longest, is the anastomosis. In other words, sewing back blood vessels with a little curved needle in and out, all around the vessel to close them, to match them,
Yeah,
right?
I see like separated that, like separating them.
Yes.
Just like again, like the valves and all that, like I there's like more like I'd say like
There's more
chance
tubing.
of Air.
Yes,
Like
and there's more tubing.
Yeah.
Here, so this is the diagram that I was talking about. All right, so it's a review. We actually have two circulations, right? We have the lung circulation and we have the systemic circulation. So we actually talk about the two hearts of the heart, or the two sides of the heart. And consider this. So the systemic circulation, let's start with the aorta, right? The aorta is the largest artery in the body. It's about a dime, the thickness or the diameter of a dime. It's a huge thing. This tube that comes out of the ventricle. Yeah, the left ventricle. Here is backwards, okay? So it's like the patient is facing this way. The left ventricle is on the right side on the diagram. So it's flipped around. Anyway, here's the aorta that goes to all the body. These capillaries here are representative of systemic circulation through all the organs and tissues of the body. And that is arterial blood, which in the systemic circulation is blood that is oxygenated, and that's why it's represented in red, okay? After the capillaries, going through the capillaries, what is that blood exchange, the gas exchange? It leaves the oxygen, the O2, in the tissue for cellular respiration, and it picks up what? It picks up CO2, product of cellular respiration, to be taken eventually to the lungs for exhale, all right? So at this capillary region, this represents all of the capillaries of the entire body, okay? So at this point, this oxygenated blood, arterial blood, drops off the O2 and picks up CO2. in the RBC, in the red blood cell, at the core, at the hemoglobin. Remember, the hemoglobin, the core of the hemoglobin is an iron atom, one atom of iron, Fe. And when that atom of iron oxidizes, becomes FeO2, right? When iron oxidizes, it's the same as rusting metal. And rusting metal looks reddish orange, and that's why our blood looks reddish, right? Arterial blood. Okay, so the gas exchange happens. Now we got venous blood coming back to the heart with CO2, and that's what's represented bluish, into the two vena cavas, superior and inferior vena cava. Anyway, they branch off and they come into the atrium, the right atrium, move to the ventricle, and then the ventricle pumps that into the pulmonary circulation. Now, here's where it gets a little tricky, because an easy way to remember is this: arteries go out of the heart and veins come into the heart. So think of the capital letter of artery, A, it's like an arrow pointing out. So that's out, all right? Arteries go out of the heart, whether it's systemic or pulmonary circulation. Don't think about the blood, think about the vessels. So arteries go out of the heart, like A, capital A, it's like an arrow. Whereas veins is a V that goes into the heart, all right? Okay, so the aorta is an artery that's going out of the heart, and it's an artery. The vena cavas are coming into the heart, so they're veins. That's for systemic circulation. Now, how about pulmonary circulation? In other words, the blood that is going to the lungs for the gas exchange again. In other words, to release CO2 and to pick up O2 from the atmosphere, right? At the alveoli. All right, well, here we have a vessel that is going out of the heart, okay? So that's going to be an artery, but it's going to the lungs. So it's a pulmonary artery. And it's carrying CO2 blood. It's carrying deoxygenated blood, and that's why it's painted blue. Okay? But it's an artery, it's a pulmonary artery that is carrying deoxygenated blood. At the lungs, the gas exchange again occurs, but in the reverse. CO2 gets off, and the hemoglobin picks up oxygen from the air that we breathe into our lungs, into the alveoli, all right? That's where the exchange happens. Now, returning to the heart, we have veins, because they're coming into the heart, all right, through the left atrium. But these veins are coming from the lungs, so they're pulmonary veins, but they carry oxygen-rich blood, and that's why they're represented in red. And where the students get confused is that they think that the veins always carry CO2 blood and the arteries always carry O2 blood. Not necessarily, that's for the systemic circulation, but for the pulmonary is reversed, okay? But the name still sticks. In other words, arteries go out of the heart and veins come into the heart. So that's how to keep them distinct. Now, for the surgery, our patient, our CF patient, needs the lungs, right? So they would have to disconnect the pulmonary arteries and the pulmonary veins. But keep in mind that the lungs are also living tissue, right? They're living tissue. So what do the lungs need? Aside from the gas exchange that they do, they also need to stay alive. So they have capillaries, and the lungs are also part of the systemic circulation. So what is not shown here is that the lung tissues are also irrigated with systemic arteries and veins for keeping them alive. So there's also systemic circulation, which is not shown here for the sake of simplicity. But you have to understand that this capillary network is also irrigating the lungs. And all that would have to be cut. Also, all those arteries and veins that are keeping the lungs alive would have to be cut, right? To do the transplant and then reconnect it on the patient. So the bottom line is that it's easier to keep this circulation intact of the arteries and veins and cut down here, just the aorta and the vena cava, and transplant the whole package. Because again, this is for purpose of illustration, but in situ, anatomically, this heart is embedded in here. All right. And so the whole package, heart and lungs, is much easier just to cut one huge artery and one huge vein, which are much easier to anastomose, than having to cut all that other circulation.
What percentage of the transplants with lungs is it normally like both lungs versus one lung?
Well, then we have to get into another detail. Let me finish the CF discourse first, and we'll address that one, okay? Because just straight up lung transplant is different from CF. The CF patient needs both lungs to survive, which is actually 5 lobes. And that's where the trick is. So what happens is the CF patient gets both new lungs and new heart as a package, which means that what do they take out? What do surgeons excise from the CF patient is the same package, the heart and the lungs, right, of the CF. So they leave the thoracic cavity essentially empty, void. It's amazing. Yeah, they open the person up with big vices, metal vices, and clip over here. Anyway, so that CF package has bad lungs, fibrous lungs, but the CF heart is intact. And that CF heart is alive and can go to a heart patient, like a friend of mine who was waiting 10 years for a heart. He got a cadaveric heart, okay? But he could have gotten a living heart from a CF patient if the match happened to be around at the time. Isn't that amazing? And so here's the one case that I know of where one can actually receive a living heart transplant and keep on living, which on average, living transplants last about twice as long as cadaveric transplants.
What's the expectancy of the organ for heart and lung versus, I mean, kidney, we know you determined, but for heart and
Yes,
lung?
I don't know. I can just go experiential anecdotally for my friend. He's about 5 years into the transplant now, and he's doing fine. The first thing he did after 10 years, he danced the cumbia, which is because he's from Colombia. He danced the cumbia with his wife, and that would have killed him before the transplant. He was at like at 10% of the heart functioning, just incredible. All right. So I really don't know the expectancies. I suspect that a lot has to do also with age and many things, but he got the heart of a 19-year-old bicycle rider. Motorcycle, not bicycle, motorcycle rider, 19-year-old. And he's in his 70s because we're about the same age. All right, so there it is. And I can see here, this was actually done not too long ago at Stanford Medical Center. So it's quite innovative. All right, now to finish this discourse for the lung, it turns out that the lung actually has 5 lobes. There's 3 lobes on one side and 2 on the other. And a person needs at least 2 lobes to be able to live. Now, a person with 2 lobes is not going to run the marathon or anything like that. You know, they're going to live a very sedentary life, but they can at least live. Usually with a little oxygen machine, and they have to carry around the tank and all that. So when you think about it, for a living donor of lung, the patient needs 2 donors because they only take out one lung, one lobe from a living donor. So the living donor remains with four lobes. The idea is not to impact the donor significantly on their lifestyle. So one can donate one lobe of the lung and keep on living a normal lifestyle with the remaining four lobes. And even less than that. I mean, there's Pope Francis as an example, is missing one lung. I don't know if it's 3 lobes or 2 lobes, but he's missing one entire lung. And that happened at a soccer accident that he had when he was a young man.
Soccer?
Yeah, playing soccer somehow. He had some kind of accident, maybe punctured the lung, who knows what. Of course, he's in his 80s, so go back 70 years ago or something like that. He was in his youth. Who knows what kind of medicine was available back in Buenos Aires at that time. Okay, but it was, from what I have heard.
I mean, I know obviously not his older, but he seems.
Well, he's delicate of health, and at times you see him on a wheelchair. But he's had other illnesses, other conditions also. Okay, but from the lung.
Years ago, you would think maybe speculate he ended up with 3 lobes because he seemed to.
It could have been that
Oxygen machine, that's for sure.
right. He hasn't been that I know of, not. Okay, so it could have been that he got the lung. I forget which one is the one that has the 3 lobes, but that's the one that was saved. All right, but that's an example where he's got either 2 or 3 lobes, and there you see him, 80 years old, going around.
But at that point, they would take out the one that got punctured or the one that got damaged, they would take it out so it doesn't become necrotic in there.
Yes, yes. I don't know exactly the details of the accident or anything like that, but I heard that he was playing soccer as a young lad. Don't even remember what age he was. Okay, so that's an example for living. Of course, the lung patient is hard up because they need 2 donors, 2 separate donors, 1 lobe each. Okay. All right. Going forward, I want to talk a little bit about the domino kidney because this one is a lot of fun. So I talk about the simpler case is this one where all 4 surgeries are done simultaneously. And here's a little diagram showing donor 1 and 2, or well, I'll just number them. 1, donor recipient 1, and donor recipient 2. Okay, so 2 pairs. Donor and recipient are not a good match for 1, and the same for the pair 2. But going across, donor 1 is a good match with recipient 2, and donor 2 is a good match with recipient 1. Now keep in mind, these 2 pairs can be in different cities, in different states of the US. But through OPTN and UNOS, the registries have found out that these 2 pairs are good matches across. So they'll meet at a prearranged place. It could be either the city of pair 1 or the city of pair 2, or a 3rd city in the middle somewhere that has a surgical theater of 4 surgeries, right? And then they're done simultaneously like that. That's kind of the simplest case. The more complicated domino kidney is 30 patients and 30 recipients. 30 donors and 30 recipients. Now, this is, to my mind, this is the largest that has been done, again, to prove that it can be done. It took 4 months to do it, and it involved 17 hospitals in 11 states of the US, a domino kidney. Started by 1, and it was literally a domino effect. So 1 donor 1 gave to recipient 2, and donor 2 gave to recipient 3, and so on, so on. 30 donors and recipients later, there were 3 patients who got a new kidney from 30 patients who got a new kidney from 30 different donors throughout the whole US. It started in California just as a occasional talk of two guys who were doing at a gym or something, or yoga class. Okay, so they were at a yoga class. I just by chance, one of them mentioned that a friend of mine needed a kidney, and so this other guy, his name is Rick, was the one who said, "Well, why not? I'll be a donor." And so they followed through with all the things that needed to be done, all the clinical check that you need clearance from. So the donor needs clearance, medical clearance from his general practitioner, from his GP, but also clearance from several other doctors, urologists, nephrologists, and there's even a neurological examination, a neurological test that is done, or a not neurological, but psychological test on the donor. Okay, the psychological test is because they ask you, well, what if you donate your kidney? It's a very noble thing to do and everything else. The recipient, the patient receives your kidney and they recover, they go home, and 2 months later, they go into kidney failure and they die. And you just wasted a kidney, right? And so that's the psychological exam on the donor has to clear that also.
There was a case that, we were recently praying for. It's a father who donated his kidney to his son. The son was little,
Yes,
like
amazing.
under the age of 10, that the child rejected.
Yes,
Like he never, you know,
Yes.
and they had to.
after the donation.
Yeah,
after
they
the
put
operation.
the father's, he was a match, they put the
Yeah.
father's kidney in the baby. He's like
Wow.
maybe 5.
5 years.
Una
Oh,
cosita chiquitica.
wow.
And,
Little guy.
and the child rejected the kidney,
Oh,
and I don't know if he had to
afterwards.
undergo surgery again or not, but he's on,
Dialysis now.
what is it?
Wow. You might, so he's on
So
the list
that's-
there. Yeah. Now, it doesn't disqualify him from another donor, you know, and another family member.
Rejection, though. It was a good
It's
match.
odd because I assume, was that here in Miami?
Yeah, actually.
So it was done through the transplant center at
I'm
Jackson?
not exactly sure
Okay,
if it was in Miami or not.
yeah, so I'm familiar with the transplant center at Jackson.
Mhm.
That's where I went. But that's the transplant center for Dade County anyway. And it's odd because you think that OPTN and UNOS, right, would kick in and find a proper match. But yeah, sometimes it happens. Again, the immune system, just kind of thinking aloud, the fact that it's a child, the immune system is not fully developed, and it could have mounted an overwhelming reaction to
Those
that.
parents.
Yeah, it's very hard, devastating. But the father is okay?
I think
From-
so.
yeah.
To check on the chat.
Yeah.
I think about him all the
The
time.
father, yeah, the father should be okay from donating. But it's the concern is the child, of course, because of the rejection. Yeah. Okay, so this was a very interesting case, and it had another layer of complexity on the bioethical part, simply because at somewhere along the line, you see the recipients are getting their kidneys before their correspondent donors are donating.
I don't think I'm following this. There was one guy who decided to donate a kidney.
Donate a kidney to a stranger.
To a stranger from
All
his
right.
yoga class, but how does the chain go? I don't understand.
Okay, so the fellow at the yoga class, I don't remember the details if the stranger at the yoga class is the one who actually needed the kidney, or it was a friend of the stranger,
Okay.
and the stranger was not a match for his or her friend.
Mhm.
But this guy, so this stranger was looking for a match for his loved one who needed a kidney. And this fellow, Rick, volunteered.
Okay.
All right. So that started the chain. Now, let's keep it simple and let's say that the stranger is the one who is the patient who needed the kidney. So Rick donated to this stranger.
Okay.
But the stranger had another donor who didn't qualify. But that donor qualified for another recipient.
Okay.
So that made the chain move forward one more link.
got it.
That other recipient had a donor who was not a match, but it was a match to someone else. So since the recipient, let's call this recipient number one, he's peachy keen because he got the kidney from Rick. But now the donor to the stranger is free to donate to somebody else.
Right, got it. So I see-
To recipient
I see.
number two, the donor for two is free to donate to someone else because their loved one already got a kidney from the previous donor. And so it moves down the chain. You know, at the end of the day, you need 30 donors to satisfy 30 patients. Okay. But it was, of course, this was planned ahead of time. Once Rick said yes, then the whole network was planned out, which took quite a bit of planning. Like 70 hospitals were involved in this. Okay. And they went forward. And in fact, I was reading the story in greater detail. That's why I put the link here. You can read it later if you like. But basically, at one point, one of the donors actually was backing out because their loved one, their recipient,
Got it.
guy had already gotten the kidney from the previous guy, the previous
Right.
person.
Right.
And so I said, well, my loved one already got the kidney, so see you
Right.
later. I'm walking. And
But
thanks
you
be
know
to
what,
God.
so this, wouldn't this kind of be like, gonna see how much it clicks with the system in Europe, where you have to have the donor, but the person stays on the list?
It can, but again, it's different because they're not done simultaneously necessarily. I'm not as familiar with the European system, frankly. In fact, I don't even know if it's kept within countries or if it's across the EU, because I don't even know. They could have an OPTN and a UNOS that is pan-European, you know, that is throughout the
Right,
whole
over the
EU.
continent.
And because it's just more volume, right? You have more potential for more donors, but also more recipients. So I really don't know how the system works over there. Being socialized medicine, it gets complicated because it's the state that's regulating all that. It's the state healthcare.
They have like your sectors of private medicine too. right?
Yeah, but then you have to pay. So in fact, you end up with two systems.
Right,
And on the socialized part, I hear again anecdotally from some family and friends that we still have in Italy and other places that if it's the state system, it's for free, or in other words, it's been paid for already previously from taxes and all that. But then there are quotas and there are delays. If you need an appointment, it's months and months in delay and all that. But if you pay, then you get the service, fee, pay per fee, whatever they call it, pay per service,
fee for service.
fee for service, exactly. And that's, so it's kind of a parallel system, but of course, many people can't afford it or just don't want to because they paid for it already through the taxes, which tend to be much higher than our taxes here, all right? So again, it's a different system. I'm really not familiar with it at all. This one I'm familiar because I went through the thing. But anyway, at one point, somewhere along the line, one of the donors was having second thoughts and backing out. Thanks be to God, they were able to convince him to please continue. And so he or she did, I don't know if it was a man or a woman, but eventually the whole domino was finished 4 months later, okay? And so that's the one that's the record, as far as I know, is the biggest one of 30 donors and recipients. But again, proof of principle that they're getting very, very creative with kidney donations, especially with living donors. All right, let's move forward a little bit here. All right, so now I go into, well, again, just to reiterate, let me see how many we have. Yeah, just a couple more slides, 3 slides. So in general, the living donation, the living organs last twice as long as cadaveric. And so they're much more convenient or better for the patient. And again, I want to reiterate that the donor has to have very good health to do that, because they're not going to risk the health of the donor. Now, normally what I do is I take the break here. In the second part, I go through the case study. That is the one that I sent you on the email for the example, which is, so I don't know if you still need a break or we can go forward. Yep. All right, so basically the example is myself, because I donated a kidney, and it was in 2007, I think it was, 2007, so here we're 23. If we were 27, it would be 20 years, minus 4, so it's been about 16 years. Okay, and the recipient is also alive. That's the lady that I was talking about, who had two previous transplants, cadaveric. And so she didn't qualify anymore. I mean, she was way at the bottom of the list, and she really didn't qualify for third transplant at that point. So it had to be a targeted donation like that. It was actually a parishioner that I had met when I was at St. Kevin Parish in the 90s. And this lady had a very complicated medical history, because she had a stroke, and she was taking care of her elderly mother and her young son at the same time on her own. And so she was already on the second kidney failure and on dialysis. And it was a royal mess, the situation. I had known about kidney donation, living kidney donation, just theoretically from teaching biology. So I started thinking about it and said, well, I could be a donor, why not? But I didn't tell her anything at all at first. Why? Because you don't want to get a patient all excited about receiving a kidney, especially in her case, that she really didn't qualify for another anonymous donation if there's no match. And so I knew that she had had her transplants done at the kidney center here in Miami at Jackson. In fact, at that time, I was actually living in Philadelphia. I was with the National Catholic Bioethics Center, and that's why the article came through the center there. You notice that the article that I sent you, this little guy, is from 2008. Where is it? I'm just looking for the email. Where it is? I'm talking about this one here. NCBC is the National Catholic Bioethics Center, where I was assigned after finishing at Purdue. They have a monthly publication that is called Ethics and Medics. Right? And so this was done a year later after the transplantation, but I was living in Philadelphia at that time. And from there, what I did is I called Jackson Memorial Hospital Transplant Center and identified myself as a Catholic priest, currently living in Philadelphia, but from the Archdiocese of Miami. And the fact that a parishioner of mine in the parish where I was a pastor previously is on dialysis, and she had had her 2 previous transplants there at the center. And before telling her anything about this, I wanted to see if I was a match, right? Because Jackson Transplant Center had her whole profile from the previous transplants. Okay. And so if it could be done, myself being in Philadelphia, if I could send the blood samples, they do, it's of blood samples, or about a dozen tubes actually that I had to send. And they said, sure, we'll send you the package by UPS. you have someone draw the blood on these tubes and send them back by return mail from the UPS thing. At that time, I happened to be, so I was assigned at this center, which, as the word says, it's a bioethics center that does Catholic bioethics at the national level, and it's located in Philadelphia. So I was in residence. I was there, assigned there full time as one of the bioethicists. We're about 5 or 6 bioethicists in different fields that were doing bioethical analysis, mostly for the bishops' conference. We put a workshop every 2 years for all the bishops of the United States in Texas, in Dallas, Texas, to update them on the bioethical issues of the time and all that. So it's a service that is done at the national level. So anyway, I was in residence at a parish nearby. Just like now, my full-time assignment is here at the university. I'm at a Simonica parish nearby in residence, which means basically room and board, they feed me and they house me, but this is my official assignment, all right? The same here. The parish where I was at there was called Our Lady of Hope. And it turns out that the pastor there was the chaplain for the Filipino community, the Catholic Filipino community in Philadelphia. I don't know if you've noticed, but many nurses are Filipinos, okay? And the reason for that is because way back, I don't know, beginning of last century or the middle of last century, nursing schools actually went to the Philippines and started nursing school programs when there was a previous need for nurses here in the US. And they started this program. I don't know why. It may be associated with the war or something. But anyway, they started these nursing schools in the Philippines for Filipino nurses who become certified and registered nurses for the US in those programs over there, which are taught in English, of course. And so once they come here, they go right to hospital, right to work, okay? And so that's why we have many Filipino nurses here in the US, and they keep coming. So those programs have been going on for decades. Anyway, and many of those Filipino nurses are also Catholic because the Philippines traditionally is a very Catholic archipelago in the Pacific Ocean. So the long and short is that this priest, Father Efren, he was Filipino also, and he was a chaplain for the Filipino community there in Philadelphia, and many of those parishioners were nurses. So I just asked one of the nurses Sunday afternoon what I was doing, what I was planning on doing, and so forth. Says, "Oh, Father, yes, fantastic. Can you draw my blood so that we can fill these dozen tubes and send them back to Jackson?" I said, "Sure, no problem." One Sunday afternoon after Mass, we both went into the rectory and she just did 1 tube at a time, filled out the whole dozen. And they're heparinized and they go to different labs for all the match thing and put it back into the package and send it to Jackson. Waited about 2 weeks and the result came back and they said, "Yes, you're a match." I said, "Oh, rats, sorry, I wasn't a match." So I can walk away with a clean conscience. But yeah, I said, "You're not a perfect match. You're like a 3, I think it was around 3 on the scale of 4, but you're a match, good enough. If you want to do it, we can do it." Now, also keep in mind, for the donor, it's no charge. Of course, this is an operation that's going to cost thousands and thousands of dollars, both for the patient and the donor. But for the donor, it's free of charge. And for the patient, the insurance picks it up. Okay, so it picks up, the insurance also picks up the donor tab. But also, they are forbidden by law to give any incentives. So they wouldn't even pay. Of course, coming to Miami, I had plenty of places where I could stay because I have family here and parishes and everything else, but they wouldn't pay the $300 round trip ticket from Philadelphia to Miami and then back there. They wouldn't even pay for that, okay? And I couldn't have her pay for the ticket either because it would seem as payment for it would be interpreted as payment. So I just had to pay it out of my own account and show the receipt of my credit card paying for the ticket and everything else, so that there was no, it had to be very transparent. There was no conflict of interest here that she was somehow paying for
Yeah.
the kidney. Okay, precisely because of the organ transplant, the organ traffic that is occurring international, the global level. So, but before, and so finally I did tell her, at first I actually had to converse her because she didn't want the kidney of a priest. I said, well, put it in prayer and see what the Holy Spirit tells you, because her own mother was not a match. The mother wanted to donate and the mother was not a match. Anyway, before doing the actual donation, I had to go through medical clearance. And I needed a clearance not only from my general practitioner, all right, my primary, I needed clearance also from a urologist and nephrologist, and that was in Philadelphia. In fact, I had a kidney stone. Let me see. This was 2007. I had a kidney stone when I went into the seminary, which was like in 79 or something like that, about 30 years prior. And I was wondering if that would be a hardship or something. I said, no, you've been fine since. It was the kidney stone passed and everything else. And so you're good to go. They gave me clearance. Yeah, and then I flew down, and my operation was laparoscopic, which is this Da Vinci robot. I don't know if you've seen the Da Vinci. It's really fascinating. No, come on. Trying to move you out of the way. There. It's a surgical robot that has several arms. And it's all done remotely. Okay. See, this robot is actually operating while this is a dummy, as you can see. But the real thing, maybe, yeah. See, it's all sterilized. And they're monitoring on the screen. In this case, the surgeon seems to be on site next to the patient. But the one who did my surgery was in another room, and it was on laparoscopically like that. So 3 small incisions, they put in through one incision, they put tubes. In one incision, they put a tube with a light and gas. They've actually filled the abdominal cavity with CO2, so they generate a chamber. They generate a CO2 chamber, right? And then a light, and then there was a lens coming in and a camera on another tube. Oh, by the way, they magnify the thing about 10 times. So the screen magnifies everything inside 10 times. So it's much easier to navigate. And this Da Vinci is incredibly precise. It moves down to the micrometer. All right, so the joysticks that they use are incredibly precise and much more than the surgeon's hand. And then on the other tube, they have actually a cauterizing machine or a tool that it works by ultrasound. It's amazing the technology that goes into it. That is actually the scalpel, if you will. It's an ultrasound machine that at the same time that it cuts through capillaries, it also seals them, cauterizes them. So there's minimal blood spillage, very, very little. The most painful thing was actually the CO2 inside my abdominal cavity, all right? Because they take out some of that CO2 after the operation. Oh, found out there was, once they were done excising and sealing ureters and all the blood vessels, right, from the one kidney. Then the last incision is around the navel, around the belly button. And that one is actually the largest incision. It's like a semicircle. And that incision only has to be as large as the hand of a surgeon, because the surgeon actually has to reach in there and grab the kidney physically to pull it out, all right? So it's a team of 3 surgeons. One surgeon is working on the patient, prepping her, and her was not laparoscopic by any stretch of the imagination. Her was a traditional surgery, open from side to side, and her surgery took about 12 hours. Also because she had 4 other kidneys in there, and there was a lot of scar tissue that they had to navigate through. All right, she had her own 2 kidneys that were nephrotic, plus the other 2 transplants, which are further down in the abdominal region, right close to the bladder. And then the 5th one that was coming in. So her surgery was much more delicate. Like I said, 12 hours by shifts on the team. There was a main surgeon on her, another surgeon on me, and a middle surgeon who actually walked the kidney physically from one theater to the other. Another little anecdote, my surgeon was a Chinese Jamaican woman, all right? She was a Chinese Jamaican woman because she had the smallest hands. She was petite. She had the smallest hands. And why that? The level of detail that goes into the surgeries, because the biggest incision on me, on the donor, was a semicircle around the navel, so that her hand could literally fit into the abdominal cavity and physically grab the kidney and pull it out. So her was the smallest hand of the 3 surgeons. Right? So
Valuable hands.
yes, so typically she's put on the donor, or the living donor. Okay, at least that's the team here at Jackson, Dr. Chan. So anyway, that's how it was done. And my surgery lasted, I think, between 3 and 4 hours, something like that. And the reason why it was able to be done laparoscopic is because they also see which of the 2 kidneys is the best candidate for transplantation, all right? And there's one kidney that's behind the liver, and the other kidney is not behind the liver. So if it's behind the liver, they cannot do laparoscopic. They have to do tradition. But mine, the one that qualified for me, was not behind the liver. I think it's the left one. And so they were able to do this. So it really was minimally invasive. I was in the hospital a couple of nights and then discharged. And like I said, the biggest pain was 2 pains. One pain was the CO2 inside. Oh yes, so they take out as much of the CO2 as possible after the transplantation, right? But they have to leave a little bit of CO2 because it's a sucking machine and they don't want to be sucking out tissue. So when that chamber is collapsing, right, there's less and less room. So they have to leave a little bit of CO2 in there. And that CO2 has to pass through the tissue passively, has to be reabsorbed by the tissue, and pass through the walls of the abdominal cavity passively and absorbed into the bloodstream and release, yes, as part of the CO2 that goes out to the lungs. So that took several days, and that was painful. You feel like there's gas in there, but you can't get past the gas. All right, so that was uncomfortable. And then I also had a pain on my back, on my shoulder, and I couldn't tell what that pain was from. And I thought that maybe it was some leftover from the anesthesia, or I couldn't figure it out because they didn't tell me. So they don't tell a lot of things. But it turns out that they put you on this prone position, and then they tie one hand with the opposite foot on the back, right? They put you kind of sideways where they stick one hand underneath, but the other hand, depending on what side it is, they cannot stick it underneath because the patient is kind of sideways. So they tie that other hand with the opposite foot on the back. It's really drastic. I mean, you don't want to see this live, okay? Because it looks painful. First, the patient is under anesthesia. So, but what happens, and why do they do that? They do that because unconsciously over general anesthesia, a patient could go like this or like this. And if a patient does like that on this instrumentation that is moving in micrometers, imagine what's going to happen inside. Okay. so that the Da Vinci machine is not touched by the patient. they tie up into some kind of tortuous position. And of course, that arm is like that for 3 or 4 hours, and it's resented back here. But they didn't tell me a thing about it, and I kept wondering, why do I have a pain on my back? And it was that thing there, that position that they use. Anyway, that was the extent of it, really. After 3 or 4 days, I was actually changing light bulbs in the kitchen of the rectory that was off. Just fine. She took about 2 weeks to recover. It was major for her. Okay. And the other thing that they do, as soon as they connect the kidney on the patient side, they do all the anastomosis and all that, and then they wait. And they wait on the patient, on the recipient, for the recipient to urinate. And once the recipient, that's the key that it worked, that the transplant worked. Okay. And also you think, well, how can that be in surgery? Because keep in mind that urine, when it comes out of the body first, it's sterile. It's sterile because it's coming from inside the body. Okay, but they have to wait after the surgery until the kidney actually starts functioning, and that's it. And then they send her for recovery and all that in the post-op rooms. So going forward, that was again 2000. It was September actually. It was September of 2007. So to the month, it's been, what do we say, 17 years? To 27 would be 20 minus 4, 23.
She's still around?
16 years. Yeah, she's around. She's still around. Yes, yeah. The kidney is functioning fine. She's had other complications since, pneumonia, and of course the stroke, which is still there and is causing other complications on her health. But the kidney itself is still functioning, right? And so she's actually literally beyond the average lifespan by a couple of years for the recipient. For myself, I'm as crazy as ever. You people see me in the forest jumping up and down, climbing trees and doing crazy things. So, so far, so good. Right? And so it's just the living proof that a person can actually donate a kidney and keep on living. Now, before I get off that case, I just want to point out one last thing that on this article, I was targeting specifically priests and nuns. All right. Here in the last part, you can read it if you're interested, but basically because of our celibate lifestyle and the fact that we're not responsible for a particular biological family to maintain and all that, number one. Number two, that I figured in my naivete that at some point, if my solitary kidney begins to fail, perhaps it will be easier for a priest or nun to find a donor than for a private individual, simply because we know many more people than private citizens do. And literally hundreds and hundreds of people get to know priests and nuns in their lifetime. So if I announce it at a parish or through Radio Paz or something like that, where I've had talks for years, perhaps some good soul will come forward and donate a kidney. I don't know. But I just figured that it would be a good noble act for our priests and nuns to consider donating a kidney. And I say typically in the 50s forward, from the 50s, I was in my 50s back then, all right? And I say from the 50s forward because before then, for individuals, maybe they're still maintaining a family, etc. But they take kidneys up until the 70s for the donor. It's just incredible. They is good, the kidney is good, you know, and as long as the person is healthy and passes all these certificates, then the thing can go forward. But anyway, so that's the little article I wrote a year later. And would you believe that? So this goes out, like I mentioned, it's a monthly publication from the center, and it goes out to many priests and bishops and religious sisters throughout the US. One bishop that I know of was motivated by this, and he ended up donating a kidney also to a parishioner in his diocese. Yes. Mm-hmm. Yeah. I met him later at one of the conferences, one of the workshops that we do for the bishops. He came up to me and says, well, your article inspired me, and I went ahead and did that. So there's a little club we're thinking of putting together, a club of solitary kidney donors. Anyway, there it is for your consideration. Back to our presentation on the last one then is some other issues that are associated with organ donation in general, especially vital organs, all right? So the determination of brain death has to be in place, and it is the total brain death like we talked about. That has to be certified clinically by the physician before, that's for cadaveric death, for cadaveric donation, excuse me. Also, consent, either informed consent from a living donor, of course, the recipient, the patient, we figured that they're consenting, but they also have to sign a paper, all right? And if it's cadaveric, then a proxy, whoever the proxy is for the person who died. Now, another issue that has come up is payment versus altruistic donation. This is an ongoing debate. And I can tell you that, for example, periodically it comes up, not in the United States, it's strictly forbidden to pay for organs or tissues or to give any kind of in-kind compensation, all right? But other countries are considering, I saw it, you know how I say, not a week goes by. Last week, again, there was an article from a news item from India, that India, the state of India, is considering whether donors, living donors, may be able to sell their kidneys or not, because of the drastic situations that they have down there, et cetera, a number of considerations. But
I don't know if it makes it right or wrong, but when you run for uteruses.
the what? Yes, right? They're transplanting uteruses.
They get paid for that.
Yes, that one, I guess, because it's not, I haven't gone through the bioethics of it in fully, right? But it's not a vital organ, right?
But if you're willing to give it or sell it, let's just say you're willing to sell it, would that at least cut back on the black market of?
That's the thinking.
You know?
That it's a thinking. In fact, if you use parallel reasoning for that, that's why a number of Scandinavian countries have actually legalized drug addiction, because then the government gets into it and the government regulates it. And so the government actually gives the needles, at least make sure that needles are sterile, so that these people don't get infected with HIV as a side, because that population goes together, you know, the addiction and the communicable diseases.
There, because I mean that's
it's pretty drastic, right? But it's a way for the government to come in and regulate it, precisely because in these countries, the organ trafficking and human trafficking is out of hand. You know, it's exorbitant. It's happening all the time. It's out of control. And so they're thinking about payment, and it's very complicated. You know, there tends to be what we call the yucky factor. The yucky factor is it doesn't sound right to be selling one's organs or tissues. But of course, we are the product of the Judeo-Christian tradition, right? Even subconsciously, our culture has a lot of Judeo-Christian values. for many cultures who don't have those kind of value systems, they say, well, it's my body, it's my organ, it's my tissue. And who are you to tell me that I cannot sell? I can sell my property, right? And this is my property. My body is my property. And so who are you to tell me no? See, so different cultures have, and then the other layer of complexity, if you want, with India in particular, with polytheism and reincarnation. They think, well, this may allow me to reincarnate into a better animal or plant or whatever, however their system works out. For us, it sounds totally out of the box, but that's their belief. So we have to be very careful when we make these arguments, that we try to ground them on anthropological reasoning that is universal, that applies. That's why I talk about evidence-based. It applies to all human beings. But we could try to make a case from the Judeo-Christian tradition that we are not really owners of our body, we are stewards of our body, right? But life itself is a gift. It's a gift from God. But then we get into religious arguments. So it's complicated once it goes international. Of course, tourism, before we talk about organ trafficking, transplant tourism has been known to occur. And at one point, it was happening quite a bit. The entire team, some people have a lot of money, and they may be on kidney failure. Millionaires or ultra-millionaires that can pay for the entire transplant team, and they can always find unscrupulous surgeons and nurses and staff to mount a surgical theater in a hotel room somewhere in China. And it was happening. Okay, they'll take a hotel room and sterilize it and cover it and so forth, and generate a chamber for a surgical theater.
Like in a war zone where they
Yes,
set up
the
on
field
spot to
hospital.
make sure possible.
Right, like the field hospitals where they have surgical rooms in it.
And this
Okay.
happens.
This happens. It has happened. There's documentation. You go online, you can find documentation on this stuff. The other part of this was that at some point, China was even providing. Why China? Because China was supplying the organs. And the organs were coming from death row inmates, with or without consent, because they were going to be killed anyway. So why waste the organ? It was horrible. It was a huge scandal. So bad, hit the international news. This was maybe 15, 20 years ago, that at some point China says, oh no, we're not doing that any longer. What does that mean? That they were doing it before. It says, no, we're not doing that any longer. Okay, but how do you verify it? Anyway, so one thing segues into the other, the organ trafficking, and then the human trafficking, and you can see it brings it up to the July movie of the year, this year in the United States, of the Song of Freedom, right? I don't know if you saw it, Sound of Freedom, Sound of Freedom. Sound of Freedom. Did you get to see it?
Yeah, it was really good.
Fantastic. You saw it? Sound of Freedom?
I can't see that.
Wow. Wow. Very
That's
powerful.
sick.
Very powerful. But
I
well,
know the story well because I've
Okay.
been following Tim Ballard for years.
oh
but
yes?
I don't-
Oh, okay.
But I don't.
All right. Well, that's the real thing, actually. The movie is based on the real thing.
Yeah.
Okay. And the fact that he was able to actually rescue children. And so that gets into the whole dark web and the depth of deprivation of humanity. And that's why people are leery about the organ thing. It's a two-edged sword. Maybe buying and selling organs, if it's regulated, it would diminish that. But again, I'm saying this anecdotally because I haven't seen the actual stats, but my intuition that drug addiction and drug trafficking and drug use has not diminished in the Scandinavian countries. It's just now regulated by the government. And so it's another layer of complexity, but it hasn't really made a dent on it. A different concept is this opt-in, opt-out. which is a concept that some countries in Europe are considering. Opt-in and opt-out. This is what I mean. So right now, we have an opt-in system. In other words, we opt into donating, okay? And therefore, when we die, our organs will not be harvested unless we have opted into donating and we become organ donors, and it goes on the driver's license, okay? And so organ donor, right? That's the opt-in. Opt-out is to flip it, to assume that upon death, I would have wanted to donate my organs, but I never stated it anywhere or told anyone. And so you can see that right away, if we do an opt-out situation, and the people who don't want to have their organs harvested upon death, they would opt out of donating. In other words, they would sign some kind of a form. There would be a national registry, etc., where their names are inscribed that they want to go to the grave with their organs, okay? And that would be the opt-out. It flips it. But you see what happens by the numbers. If we flip it, then on a particular nation or country or region or state, the assumption is that upon death, these people would have donated their organs unless they opted out. So right away, you generate a huge amount of organs and tissues available for transplantation because people are dying all the time. Not everyone's going to qualify, of course, again, depending on how they died. Anyone who was ill, any cancers, anything like that, they don't qualify, fine. But the ones who are dying healthily, typically from traumatic brain injuries or even a heart attack that leaves the cornea intact, for example, don't have to be vital organs, right? The opt-out has possibility to do it, but how to do it ethically.
Is that being discussed like at governmental levels now, like federal
Yes,
or state or?
several countries in Europe are talking about this in their general population, right? Now, it's a possibility, it's an open question. But imagine this would involve what? Well, it would involve typically a massive education campaign, starting with elementary school kids, that basically you are steward. It goes back to the whole thing. You're steward of your body, but you don't have to take your whole body to the grave, all right? You can, upon death, so now you're a cadaver and your organs are going to rot inside a grave. So why not be altruistic, and donate them upon death? Of course, it would have to be done age appropriate and so on and so forth, but I could see a massive national campaign done in the school system, all the way across the grades, elementary, high school, in families, that families will talk about it and so forth, and also at the same time provide the forms very readily available for opting out, right? Throughout one's lifetime, and also with a possible
organ donation. Like, yeah, I guess.
Yeah, you think about it, I think it has potential, but it would have to be a massive national campaign of information and dialogue, and even townhouses to talk about it. It would have to be legislated very, very precisely, so that people have ample opportunity to opt out or opt back in, to cancel their opt out and so forth throughout lifetime, life changes. Imagine, let's say I opt out as a teenager. No, I want to take my organs with me. Okay, fine, opt out. But then my younger brother in my 30s or 40s, my younger brother goes into dialysis and needs a kidney, all right? I don't want to donate him alive, but if I die, I can donate. Or if I'm a parent, I can donate to one of my children upon death. So it starts making sense when you put it in the context of the loved one, who's the one who needs it. they would have to go to that list. But I can tell you, if we go into an opt-out system, these numbers will be wiped out. Okay, because you're going to have plenty of organs. And imagine, we are, what are we, 320 million people in the United States? Imagine how many die on a daily basis that may have healthy organs. Maybe the heart is not healthy, but maybe the lungs or the pancreas is healthy, right? Diabetes. Another thing I wanted to mention, going back to the article, since I went back to the slide, I figured that by the numbers on this article here, I did the math somewhere, and I think it's like 0.01% of the adult population in the United States. If 0.01% of the adult population in the United States donated a kidney, we would wipe out the 100,000 that are on the waiting list, just by the numbers.
So maybe we need to do some education on the fact that
Living
still
donation.
have a completely normal and fruitful life
Yes.
with one.
Improve. You
Right.
can continue to live as crazily as before, and it can happen, you know. Of course, maybe not everyone qualifies. Maybe I just had a very good health and all that, but yeah, it's true. But anyway, this opt-in is opt-out. Again, the last slide is always open questions, right? But this may be a possibility. And like I say, some European countries are thinking about it, but it would involve a massive educational campaign and dialogue happening through society, maybe even vote on it somehow, who knows? But that opt-out and has to be very available for the people so they don't feel constrained, all right? It might also, you have to take into account psychological and sociological factors that if everybody is in agreement or most of the people in the society are in agreement, but I don't want to, I may feel pressured by the rest of the people around me to do the same thing. So there's that social pressure, right? So complicated, but just to say that people are thinking about it. And one way or another, it's because of the tremendous advancement that has happened on the clinical side and technological side with organ and tissue transplants. You know, it's been perfected and perfected as we go along. And so decades ago, few people actually survived organ transplants. Typically, they were cadaveric and all that. But today, most of the recipients are surviving and thriving and are recovering lifestyles that are very active and so forth. Okay. So that's the presentation on the transplantation scenario. You see there are quite a few of the issues involved. Technology continues to push it forward, but still we cannot bypass the human factor of consent, of course, which comes with information. And so to get this information out to the people is an important thing. There are also in any society some ethnicities that are either at greater risk or greater need for some transplants. And for example, in the Black population, they have some particular illnesses that are more susceptible to transplants. In the Jewish population also, because of inheritance and so forth. So those are other things that are coming to play with about ethical issues on organ and tissue transplant is the ethnicity of the donor and the recipient. Okay. Okay, folks, so this is where I leave it with the organ and tissue transplantation, the bioethical issues. But you can see it's kind of it's an exciting topic, right? And we have to navigate through all the different layers of it, but it's navigable, is what I'm saying. It's navigable. Many counties have, or at least at the regional level, they have transplant centers where all this takes place. Okay, so that's about it. We're early today, so I'm gonna close it here unless there are any other comments or questions. If not, then we just have to decide on when to do the next one in person. Let me finish the recording so I can start downloading. And then, like I said, I'll send you the links for the 6 virtual talks, okay? And then we can decide on the other one in person. So I'm gonna stop the recording now.